Thank you so much. All right. How are we feeling? We're good to keep going? Good. So our next speaker, Ms. Latoya Delmadge. She's a licensed clinical social worker. She's currently the Director of Social Work and Behavioral Health Department at Kings County Hospital. She previously developed an Article 31 and 822 base clinic in Brooklyn, treating children and adults with serious mental illness and comorbid conditions. She specialized in mindful-based trauma treatment and has obtained extensive training from Harvard University on trauma-based treatment and mindfulness practice. She's currently a doctoral candidate at Liberty University in Lynchburg, Virginia. And as a current member of the Social Work Directors Council for New York City Health and Hospitals, she is a devout advocate for the social work profession, social justice, health equity, and behavioral health for the public health system in New York City. Please join me in welcoming Latoya Delmadge.
It is still morning. I know we got a lot, and I know it feels like it's the afternoon, but it is still before 12 o'clock. And I just want to say happy Social Work Month to all of the social workers in the house. And I also want to say happy National Women's History Month to all the women in the house. Now, that was a very powerful, powerful panel. And I have to say that it kind of brought me back to my Jewish board days, because I, too, am a product of the Jewish board, or should we say JBFCS. And I remember the days of sitting in staff meeting. Now, our staff meetings weren't meetings of complaining about anything else. Our staff meetings were filled with discussing cases and getting the best lens that we can obtain to be able to provide the best treatment for our families that we were serving at that time. I also realized Melissa brought it way, way back to FTCs. And I remember sitting through so many FTCs and walking away with, this is what I know our family needs, and looking at all the lenses and bringing the best approaches to our treatment. So I want to thank Shirley DePena. She has not changed a bit. So that fiery Shirley DePena, she's always been the same. Shirley DePena was the one who provided me my first placement. And when I was so focused on doing clinical work, as we thought was clinical work, working in a clinic and an outpatient setting, Shirley said, you need case management experiences. It's going to help you. And I'm so happy that I received that advice. But also Merville Antoine, who was one of the biggest advocate for our family. She was a senior social worker when I actually started my career. So I really sat under a lot of influence at that time. And how could you sit under that kind of influence and not experience exponential growth in your career as a social worker? So we always have to go back where we came from, and it's so happy to see all of them. I can't go on without recognizing some of the staff who I get to do this work with. I have some of my team members from Kings County Hospital. I want this whole room to make noise for them, okay? They're a big deal to me. So we have with us our Associate Director for our Acute Care Services, Alexandra Summerstein. She is the resource guru. As Melissa was talking about her services, I see Alex writing something down. I was like, you writing that down for the clients, aren't you? She said, yes, I am. She makes sure that she finds the best resources that is going to help our clients, and she advocates for those resources. So shout out to Alexandra Summerstein, our Associate Director. We have our mobile crisis team here as well, Deborah, Nicole. Our mobile crisis is a big deal. When our staff are in the offices working on their computers. When 5 o'clock comes and they get to rush out, when there's a rainstorm, as we've experienced quite recently, or a snowstorm, and we get to go home early, our mobile crisis team is still out in the fields, in the homes, providing crisis services to our families. So shout out to our mobile crisis team. And we have our comprehensive psychiatric emergency program, our CPEP, our supervisor, Taye, who's also in the house. We have our child and adolescent outpatient team. Sean, I see you. Andreen, I see you. They're here. They're in the house. He said, we're talking about child services. So we want to make sure that we're here. Child trauma. We want to make sure that we are gaining as much resources as we need to be able to take back to our work that we do with our children. So shout out to our child and adolescent outpatient department. We also have Mussolini. Is he here? Mussolini, you're graduating in May, right? Are you from here? Is it from Medgar? From Stony Brook. So we have upcoming social workers as well who is doing great work, and we want to recognize them. So in honor of social work, I always take great pride in recognizing the great work that our team does, and we do it all together. So today I have the privilege of talking about trauma-informed care and fair compensation for social workers. Now, I'm not going to reteach trauma-informed care because I believe that we all have some foundation about trauma-informed care. However, what I would hope to do today is to empower you to implement trauma-informed care in your regular practice. Sometimes we get so caught up in some of those big interventions that we use, like CBT, and everybody wants to do DBT, and all of that is relevant to the work, but it also goes back to the type of treatment that everyone can provide to our patients or our clients, and I'm going to be using those terms interchangeably as we go throughout this presentation today. So I actually want to mention something as a director at Community Counseling and Mediation. It's a community-based organization that has many programs, and I was privileged to start up one of their most recent Article 31 clinics before starting my position at Kings County Hospital. And when we were starting up that program, I had the privilege of hiring new staff. It's a brand new clinic, a new office that was renovated on Clinton Street, and I was able to hire brand new staff for this program. So when you're hiring staff, especially social workers and clinicians who's gonna be doing work, sometimes hiring managers or leaders or directors think to hire people who have a lot of experience because you want them to come and you want them to do the work. It's not an internship. This is work that they're getting paid for. And, they always want to hire at least 1 year experience after graduation or 2 years experience after graduation. But I always develop a love for new social workers who had these skills. They were just coming out of their internship programs and they were fresh. So they had all this information and they were ready to implement it in their practice. And I had a mixture of both though. So I did need some seasoned social workers and clinicians, but I also wanted some fresh social workers who were new to the field. And so I remember interviewing this gentleman. He was fresh out of school, but during the interview, he talked about all that he learned during his internship, and he also talked about how he actually implemented all he learned in his practice. And that's what he wanted to bring to our clinic. So he was about maybe 3 weeks in and slowly building his caseload. And I'm sitting in my office, and the front desk calls me, and they're like, Latoya, you got to get up here. The minute I get up there, there is, I think the young boy was about maybe 12 or 14 years old, full-blown tantrum because he didn't want to come in for his intake appointment. So his mom brought him straight from school. His mom just got him back out of foster care, and she brought him straight from school. And she didn't tell him that he was going to see a therapist or going for an intake appointment because she knew that he was going to be, as I know Shirley said, we don't say resistant, but we knew that he was going to be resistant to the process. So when he came in, he was having a full-blown tantrum. He was not hitting anyone, but he was using a lot of derogatory words to the front desk staff, to his mom, and attempting to leave, and mom was trying to keep him from leaving. So when I came out, the first thing that we do, because I did have some experiences in crisis intervention. And I'm like, we were able to kind of like get him in a hole. And the first thing you always want to do is remove all of the audience, right? Because sometimes when they see an audience, they can put up even more of a show. So we brought him back to my office, and I told Mom how to hold him and bring him back to my office. I put on a little bit of music, and the overall goal that I wanted was for him to just calm down a little bit so we could understand what the trigger was or what was happening to him. After maybe about 20, 25 minutes, we were able to get him to calm down. And during that time, I was very transparent with him and his mom. I'm like, listen, if this continues, we're taught to call 911 and we need that crisis intervention. I said, however, I don't think that's going to be beneficial for you or for your son. So I said to him, if you don't calm down, that's what I'm going to have to do, but that's not what I want to do. He was able to calm down. And the person who I actually scheduled for him to do an intake with, I decided in that moment, I didn't feel like they were the right person to meet with this young boy and his mom. So there was the same gentleman who was about 3 weeks in, fresh out of school, fresh out of his internship experience. There's one thing that I noticed, and that was how warm he was with all of his patients. I noticed his level of engagement, how he really engaged with them. He would be in the waiting room and he's already talking. They're walking together. He's walking side by side with them and they're engaged. And sometimes when you see clinicians, when they're walking their clients or their patients to their offices, they're always like so many steps ahead of them and they're all the way back there. But one thing I noticed with him is that he's walking with his patients when he's taking them in and when he's taking them out. So then I said to myself, I'm like, you know what? I don't think that this person who was supposed to do the intake with him would be a good fit. I think I know what I'm going to do. So he comes in because the whole office heard him. So they knew who is she going to call in to do this intake. So when I call him in, he already comes in and he's looking like, I'm new. When he came in, I said, we're going to call him Joe. I said, Joe, actually he came in and he introduced himself to the gentleman, to the young boy. He introduced himself to the mom. And I explained, this is who's going to be working with you. After they left, he engaged with the little boy. He asked him what he likes to do, what work is going to look like with him. After he left, he came to me and he said, do you really think that I can work with him? He seems like he's pretty high risk. And I said to him, I was like, there is layers and layers of trauma that you're going to have to work through. I said, but what this family really needs is someone who's not going to judge them and who's going to be patient with them in the process. The young lady who was actually scheduled to see this intake comes to my office immediately after, and she's like, there is no way that we can engage him in this office. He needs home-based services because it's going to be traumatizing for all of the clinicians here and for all of the patients. Not realizing that the same patient we saw coming in left completely different than how he first presented himself. So one, she was not able to recognize that transition in his presentation. So I said to her, I was like, I didn't really respond to her. I was like, I have another meeting that I have to hop on. But in my head, I'm like, that's the reason why your no-show rate is so high. That's the reason why your patients don't show up, right? Sometimes clinicians coming in like, oh, they're not showing up. But I really have to ask the question, like, how do you engage your patients and how comfortable do they feel meeting with you? So what I really want to talk about today is that it's not just your years of experience as a clinician. And I know that we don't only have social workers in the room, but it's what you take with that experience and how you actually apply it to your practice. So I had to look at this quote, and I don't know why the author of this quote is unknown, because if I came up with this quote, my name would be written all over it. It's really good. It says that trauma is a result of an overwhelming sense of danger, powerlessness, and fear. Healing, this is where we come in as clinicians. Healing is a result of feeling safe, feeling empowered, and feeling supported. And we have to say that sometimes our clients are meeting with us and they may not feel safe in our presence. We could be engaging with them and we're not making eye contact, or even sometimes something as simple as coming down to their level. When he came into my office, he wasn't standing over the patient. He kind of like came down a little bit and he made eye contact and leveled up with the young man who was in my office at the time. and sometimes they may not feel supported. So we have no power and control over patients' or clients' experiences or their trauma experiences, but we do play such a vital role in that process. And it is a process of healing through the level of support that we provide to our patients. So as I mentioned, I'm not reteaching trauma-informed care, but I am hopefully, what I'm hoping to do is to empower you to carry this practice out every day, because it does make a difference in recovery outcomes for our patients. So in doing that, what we will do is we will define trauma, and a lot of this is going to be overlapping with what we've already heard from Dr. Sullivan and from Amaya. Thank you so much for sharing your experience. We're going to talk about peer support as well, but we're going to explore the history of trauma and how it impacts the brain and development. We're going to define trauma-informed care so that way we make sure that we're all on the same level, we're looking through the same lens. We're going to explore the history of trauma care and its 6 principles. We're also going to explore trauma-informed care and practices, and we're going to discuss how trauma-informed care is intrinsic to the social work profession. There is no trauma-informed care without social workers, and there is no social work practice without trauma-informed care. So, as already has been defined, according to the American Psychological Association, trauma is defined as any disturbing experience that results in significant fear, helplessness, dissociation, confusion, and other disruptive feelings intense enough to have a long-lasting negative effect on a person's attitudes, behavior, and other aspects of functioning. But I like SAMHSA's definition of trauma as well. SAMHSA defines trauma as an event or set of circumstances experience. So it's all about the client's experience. You may have experience and you saying, well, that wasn't traumatic for me, or why would you respond to that situation that way? It is not about your experiences. It is about the person who experienced it. And they experience as physically or emotionally harmful, that has lasting adverse effects on an individual's functioning. So the key terms that we want to think about when we think about trauma is the experience and the effect that it has. I know that trauma has become like a term that is used by everybody, because we think of trauma like anything that's affecting my psyche, anything that's affecting the way that I think, like that was traumatic for me, right? So it doesn't necessarily have to be that you had a major car accident, or you were in an earthquake, or you experienced domestic violence, but you experienced something that required more of you than you can actually give emotionally and psychologically, and it impacts the way you think long-term. It impacts the way that you show up in relationships. It impacts the way that you engage with people. How does it impact your brain? And we're gonna talk about specifically about the brain functions, but right now, we want to focus on how it impacts you physically, socially, emotionally, and I love that Dr. Sullivan made sure that she included this in her presentation, how it impacts you spiritually. And I'm going to talk about why that's so important for the communities that we work with. So the way that trauma impacts you physically, according to SAMHSA, research continues to reinforce the link between traumatic experience and impaired neurodevelopmental and immune system responses. Socially, we think about isolation, and we realize that loneliness has become a major epidemic right now in our community nationally. But at the same time, it's like how many of our clients or patients are dealing with social isolation for a lot of different reasons, right? Hurt from the past, or having experienced, violence in the past, and ways that they keep themselves safe is by staying to themselves, right? So we want to think about being guarded or afraid to leave the home. When you think about violence that we experience, gun violence in our community, sometimes people, it's not that they want to be homebound. Maybe they want to be out there engaging with everyone, but maybe I might be that victim next time. So I go home, If I have to go to work, I go to work, and if I don't have to, I don't. And even how much it impacts people to the point where they can't go out to work, right? So it impacts their functioning or their ability to care for themselves. Emotionally, inability to regulate emotions. We see a lot of our children in our school systems, as was talked about, they're not able to regulate emotions. And what are they characterized as? Having behavioral problems or having issues, or their disruption to the classroom, rather than they could be having a trauma response. Spiritually, there are a plethora of research studies that really shows the link between spiritual and religious beliefs among the Black community being a support system. So the church for the Black community is a huge, not only social support system for them, but also emotional support. So what happens, as Dr. Sullivan has already mentioned, what happens when your only source of support is your church or your beliefs, whether it's in God? And that becomes disruptive because now you are blaming what used to be your support as not being there for you, or not showing up the way that you expected it to show up, or protecting you from the experience that you have. The fact that that didn't happen, now I no longer have that support. And then they show up in your setting, whether it's in an emergency setting, whether it's in a hospital, whether it's in an outpatient clinic, and you don't do that assessment to figure out what their spiritual beliefs are. You completely pass over that and don't realize how foundational that is to their ability to then recover from their situation. We have to tap in on how trauma impacts our clients and our patients spiritually as well. So the transactional model of coping, I really want to point this out because it points out that stress results from any discrepancy between the demands of the situation and the availability of the resources or ability to cope with the demands. So we go through what they call, two separate appraisals. The primary appraisal is where you're kind of making an assessment and trying to figure out, is this harmful to me? How much does this require of me? Do I need to engage or not? If it is something that you have to deal with or you have to engage and you realize that it is going to be a danger to you, whether it's psychologically or emotionally, your second appraisal is that you're tapping in now to your coping strategies. I was on my way here this morning and someone called me while I was on here. I'm focused on doing a presentation. And, I gave them the time of day. I did answer the phone. I probably shouldn't have. But they went on, it's like they were waiting for me to say hello. And they went on and on and on. I'm like, I am not in a problem solving mode right now. Like, I don't want to help you problem solve. I don't want to help you find solutions. I don't have the time, right? And some of us are empowered to be able to say, you know what, I don't have the time for this right now. Or, you know what, you're not healthy for me right now. Or I don't have the capacity or the resources emotionally or mentally to deal with you right now. So I'm going to put you over there. Some of us have the empowerment to be able to do that. But what happens to maybe some of our children who are living in some homes where their only dependence is on that parent who abuses them, right? So even though their way of coping sometimes is the responses that we're seeing, right? The way how they're showing up maybe in school. Their responses sometimes is maybe their isolation. At times we don't really see their inability or the lack of internal resources to deal with their situations. We just see the presenting problem. So I think looking through the lens of the transactional model, we are able to really understand the demands sometimes that are on people or individuals to deal with certain situations that they don't really have the resources to be able to deal with. And that lens in itself can help us to have more of an empathetic stance or view when it comes to our patients. And that's what I really want to capitalize on, is the way you're viewing sometimes the patients or the clients that you're dealing with. Is it through a trauma-informed lens? So according to Mihalikova and his colleagues, trauma may result from social factors such as poverty and can be a precipitating factor for poor mental health, substance use, and homelessness. In a meta-analysis review, it revealed the one-year prevalence rate of post-traumatic stress disorder among individuals diagnosed with schizophrenia which was approximately 17%, a rate which is much greater than the general population in the United States. When we think about trauma and mental health, they go hand in hand. Sometimes trauma can come first, sometimes mental health disorders can come first. But when we see patients that present to us, they may not disclose their trauma right away, but when you begin to hear their stories or even think about maybe neighborhoods that they potentially come from or things that you already know, because sometimes we have histories of our patients or our clients before we actually sit down with them, we want to make sure that we put on that trauma lens right away. And even though we don't hear it from them, we start to engage them as though we already know that they have trauma. They have a history of trauma. So the importance of services that are responsive to the needs of individuals with serious mental illness and trauma histories cannot be understated. You first have to assess and get a really good sense of who is sitting in front of you, and then you're able to determine what does treatment look like for this individual. Trauma can also be experienced on an individual level or a community level. So one thing I want to note when it comes to homelessness, and we know that we're also dealing with this on a larger scale. We have patients sometimes showing up to our setting who's homeless, and it's like we want to do, but it's like we lack the resources. But at the same time, we can help them as much as we can to navigate the system, but the support and empathy that we provide, they need to know that you're there to help them. You're not judging them because of their current condition of being homeless, but you're here to support them and walk them through the process, whatever that process may look like for them. But data from the Coalition for Homeless reflects, in New York City, the homeless shelter population, the number of homeless people sleeping in New York City's main municipal shelter system, this is in 2000, this data reflects from 2023, for families, it's 21,000 people. For homeless children, that's 33,000 people. The numbers have probably grown since 2023. That's a lot of people who are without secure shelter, and they're showing up to us. And, you know, our system, as we were talking about systemic racism, and we're going to get into that, it's failed our children. It's failed our families. When we think about the amount of incarcerated individuals that we have who maybe were one of these homeless individuals at one time, and we talked about the lack of services that's being put in advance to help stop these trends, what more can be done? According to the national, there's also like a number that I wanted to point out, but just looking at those numbers is very alarming, and most of those patients are showing up into our settings. But on a whole, the amount of individuals in DHS shelter system, on a whole, families, children's, individuals, 91,000 people. That is a lot of people. So we want to also make sure having this information helps us to understand how deep this goes when it comes to trauma. Because a lot of people are living in traumatic situations because they're homeless, or because of their trauma could have led them into homelessness, and they are reaching out for help. Trauma can also be experienced on an individual level or on a community level. We're thinking about individually, so sexual assault, intimate partner violence, abuse, child abuse, and neglect. Wow, this is much smaller than I thought, sorry. Some more statistics. According to the National Institute of Health, domestic violence is common. Why is that word even associated with domestic violence? It being a common practice. So it's common for us to wake up and brush our teeth. It is common for us to take a shower. It's common for us to eat. Why is domestic violence a common practice? And it is estimated to affect more than 10 million people in the United States. Some domestic violence experience, of course, as we know, begins in childhood and continues to adult relationships. So sometimes we're looking at adults like, why did you choose him? You know his history. He did this to this one and he did that to that one because of trauma. it changes your brain. It changes your ability to rationalize situations. It changes your ability to even have a self-esteem where you can be like, you know what, that's not good for me. So we really need to, I want to say reduce our judgment. I really want us to be void of judgment altogether, but I don't think that's realistic, so I'm going to be as realistic as I possibly can. We want to reduce our judgment. That because of your own history, right, with abuse, with domestic violence, with sexual assault, you can be bringing that same lens to why you accept certain men or women into your lives. Maybe you never had that example, and we're going to talk a little bit about intergenerational trauma, as Melissa also mentioned earlier. According to the National Council of Behavioral Health in the United States, a woman, I think I've been up here for, did I start my clock? I did not start my clock. I think I've been up here maybe for more than 10 minutes, I would probably say. But a woman is beaten every 15 seconds and is forcibly raped every 6 minutes. How is that even possible? How much, I'm not doing the math, I'm not a mathematician. I don't like quantitative data either, that's why I chose qualitative. I don't like numbers too much, but I sure do manage it well when it comes to my bank book. I don't know how much that actually equates to over 24 hours, but in a week, when we're safe in our homes, sometimes the patients that's showing up to our setting have been beaten more than 10 times maybe before the last time they came and seen you. So we're thinking about that as we engage them. And we know about, domestic violence. That is a cycle that is not hard, that's not easy to break. It takes years, maybe sometimes, to be able to support our patients in making a change. Trauma is also, Trauma is also experienced on a community level. So we're thinking about the lack of resources and poverty, in particular communities, systemic racism, and violence in communities. When we think about also the impact on individuals physically, and I had to bring up this model just to create a better visual on, the different layers sometimes that people go through with trauma. It's not only impacting you individually, but it's also impacting your close families, your close friends of some of your clients and patients. It's impacting us socially, and it's also impacting us on a community level. Physical health, mental health, relationships, life trajectory, self-esteem, and so much more is what some of our patients and clients are going through because of trauma. The impact on close family and friends. You want to think about the demand to be able to support someone who is going through a traumatic situation and has a trauma response. You don't understand it, but you got to show it for them and you got to support them. As we were talking about with in the vignette that we just went through, you have a grandmother who's probably going through her own physical health issues, who's probably going through her own mental health issues, and she has to be there to support her grandchild. It takes a demand. We have parents maybe who have 5 kids, 4 kids, right? Who they have their own mental health issues. They have their own histories of trauma. Their children, maybe 3 out of 5 of them, have an IEP that they have to take for services. Maybe that they're trying to get back out of the custody of ACS and have to go through all these different programs to prove I am fit now as a parent to be able to. It demands a lot also from our families. When we think about how it impacts our environment, withdrawing from family, who's a big part of our support system. We see a lot of patients who struggle with trauma history, have a hard time trusting, and they isolate from their very families, who's actually trying to support them and is their only support for them. But they see them as a threat to their well-being because of so many different reasons. And we sometimes, as service providers, we try to make sure that we're incorporating the families, we're trying to incorporate their support system, and they're resistant to that process. And we can judge them as to, look at how you are, not really taking advantage of the systems that are here to help you and taking advantage of people who love you. But you don't know the full story, and you won't know the full story until they are able to trust you enough to let you in to the reason why I think the way that I do, the reasons why I do the things that I do, the decisions that I'm making. This is the reason why. And it takes time to get clients or patients to that level. Impact on the community. I talked a little bit already about violence and fear, psychological impact, mental health, and the ongoing cycle of it. So you have mothers who's went through it. Now daughters are going through the same thing. Now, and the cycle goes on and on and on until it gets to the point where somebody realizes this has got to stop, and it's going to stop with my generation. So systemic racism is a term that was invented in 1967 by Black activists, Stokely Carmichael and Charles Hamilton. And really systemic racism, as was already talked about, is systems, really racial systems of hierarchy, that one group is more, has more of an advantage over another group. And it's systems that create the advantages of others and also the disadvantage of our Black and brown people, communities. We think of neighborhoods that we go to, and you see the disadvantage. I read this book. Has anyone ever heard of the book, Our Kids, The American Dream in Crisis by Robert Putnam? No? If you have not read that book, I implore you. It is such a good book. Robert Putnam does not focus solely on the poverty of our Black and brown children, but he mostly focuses on how class and how race or disadvantages or advantages of some social groups create more of inequality and like a class system where more middle-class children may have more access to resources, and because of the access that they have to resources, or is that time? You're saying time? Okay. Because of the access that they have to resources, they're able to accomplish certain things in life or reach certain statuses in life versus someone who don't even have any opportunities for that. Some of our children are showing up with no opportunity. And so how do we begin to work with them? One, to connect them to opportunities. And yes, case management services and resources are very important because we have to look at what are the resources that our families have or don't have, and how does those resources or the lack thereof impact their outcomes. I want to touch a little bit on adverse childhood experiences. We cannot talk about trauma without talking about ACEs. In 1998, Felitti and Anda conducted the first ACEs study. It has went on where SAMHSA, I believe, also has adopted their principles and expanded from the 5 principles that they originally had to a 6th principle. So adverse experiences impacts brain development and health. And when we think about children who are in abusive relationships or in homes where there is constant abuse and neglect, caregiver, mental health issues, as we talked about in domestic violence, when we think about also generational trauma or transgenerational trauma, when children come into the world, yes, they inherit physical traits, like they have their mother's nose and eyes and lips and all of that stuff, but they also inherit their narrative. They also inherit their trauma. They inherit their lens of how they see the world, which then impacts how they show up in the world and how they feel in the world. So I'm not going to go into the impact on the brain, but I do want to point out that trauma impacts how our brains are developed, and it changes it completely. So we have the amygdala, which is pretty much our alarm center for the brain. So it senses whenever there's danger, and it puts us in that fight or flight mode. What happens with trauma is that the amygdala becomes more active or more sensitive to even situations that may not be dangerous to you, but actually sees it that way. The hippocampus, which regulates emotions and also is key to some of our learning, that even though the hippocampus becomes weaker, the connection between the hippocampus and the amygdala becomes stronger. So the hippocampus sees a new threat, it remembers something, and it sets off the amygdala, and you're constantly in this hypervigilant state, and you cannot regulate your emotions, which the prefrontal cortex, we want to talk about that as well, which is responsible for your logic and your reasoning. So sometimes we have patients who show up very anxious, very irrational sometimes, very illogic, and you're wondering, they're irrational, and that's what we're putting in their documentation. And in that documentation of their presentation, they're irrational, they're very anxious, they're not able to regulate their emotions, right? We're not putting that it could be a trauma response. And so we want to make sure that we keep this language and we keep this lens in our practice. I want to just speak a little bit about the constructivist self-development theory, because this has helped me a lot also in my practice. It considers psychological resources and needs of individuals and defenses. CSDT proposes that individuals construct their own personal realities as they interact with the environment. So they have 5 iterational aspects, which are self-capacity, ego resources, frame of reference, psychological needs, and cognitive schema. And also, I wanted to bring about Maslow's hierarchy of needs, because sometimes a lot of our patients are staying right here where we're only thinking about, or only thing that we can even work on right now is their physiological needs and safety. We get stuck there. So we're talking about this cycle that we go through because they're not able to reach it to the top of self-actualization. Can generational trauma actually end if only thing that we're able to work on is our basic needs? So it's like when we work with our patients, we want to think about how we're graduating them to the point where now you feel safe, especially when you're with me. How do we make you feel safe? How do we make you trust us through our engagement with you? How do we graduate you to a place where now we're focusing on your psychological needs? We've established that, and now we can move into your self-fulfillment or your self-actualization. Some of our clients actually want more. They want more out of life. The same way how we have motivations and we have ambitions, our patients or our clients who struggle with trauma, who get stuck in certain systems in their life, they want more, and they're looking for us to partner with them to use the strengths that they already have to graduate them to that level. So I want you to think about, even as clinicians, don't just stay in basic needs. Think about how you can work with your clients long enough. We don't want to just put time frames on it, and our time is not their time. I am willing to work with you for as long as it takes to get you to a place of self-actualization. So trauma-informed care, some of the themes that we want to focus on really is realizing, and everyone in our system, in our spaces, in our organizations, they're realizing the impact of trauma. They're recognizing how trauma affects individuals, and they're then implementing practices to prevent re-traumatization. I'm going to skip over this, and I'm just going to talk a little bit about the principles of trauma. You always want to think of safety. Do my patients or my clients feel safe? Do they trust me? What does peer support look like? For our children, peer support can be their families. It doesn't necessarily have to be someone, but we heard Amaya and how powerful her lived experience is. We never want to remove the power of peer support. Collaboration. We want to collaborate with other providers maybe that they may be connected to, and we want to partner to make sure that we're all working on the same thing to get our patients to a specific goal. Empowerment and cultural safety, which was added by SAMHSA. So I'm going to hop over this, but I want to talk just really quickly about trauma-informed care in practice and what the outcomes look like. In a naturalistic study wherein data was collected between 2012 through 2018 on 547 youth between the ages of 12 and 18 who resided in a trauma-informed residential care setting, changes in symptoms of PTSD, depression, dissociation, psychological dysregulation, and externalizing and internalizing problems were measured over 21 months. Study results showed a significant reduction in all indicators, both for male and female, but there was more of a greater response to this treatment for females. In a study, a quantitative study, post-traumatic growth was measured among 32 bereaved children, ages 6 to 18, who attended a healing camp that provided trauma-informed care. And study participants had either lost the father, mother, or grandparent, or sibling, and study results showed a significant increase in post-traumatic growth. So trauma-informed care works. And I don't want us to just have a knowledge of it. Doesn't matter how many years you've been in the field, doesn't matter how many letters you have before or after your name. If you're not applying it, all of those years of your education and your training does not account to anything, because trauma-informed care creates differences in our patient's life. So I want you to take this with you. When you're going for your interviews, when you're trying to negotiate for bigger salaries, just like that new social worker came into my office and he talked about all the skills that he gained and how he used it currently, you want to talk more about how you're impacting systems, how you're changing systems, what you've learned, and how you're applying it to your practice, and make sure that you begin to make demands on what you know your skills and your practices are worth. Thank you so much.
Dr. Boone.
Lionel, come. Let's go. Sherry, Marvell. Let's go. They have photographers for that.
So I think I speak for the whole committee that this conference would not be made possible if it was not for the leadership and dedication of Dr. Wally Boone. Now, he looks a little surprised because this is not in the program. I wanted to read Dr. Boone's bio to you all. When asked for his bio, it was probably the shortest bio I have ever seen. It was 2 lines to be precise. However, I would like to propose an alternative bio for you, Dr. Boone. Dr. Boone is one of the graduating members of the inaugural class of the BSW program here at Medgar Evers College. And during his time here as a student, he was one of the founding members in creating the ASWB chapter here at Medgar Evers College. And he went on, even through hardship, still got his master's in social work at Hunter College. And then he came back to this very institution and worked in admissions to continue to recruit the next generation of change agents, educators, and social workers. And for those of you who do not know my story, I would quite literally not be a social worker or have graduated from this institution if it was not for the gentleman who walked through the admissions door in April of 2017, actually. And through that, he still got a second master's in higher education from Baruch College. And he was told about a need here on campus. He was told about students suffering from housing insecurity, sleeping in their cars, staying in shelters, being evicted, students who were going hungry in class. And that's when, in 2018, he became the founding director of the Transition Academy here on campus. And I was an intern for Dr. Boone in 2019 into the spring of 2020. So during the coronavirus pandemic, when it was first starting. And I can tell you that Dr. Boone was here during the lockdown the entire time. He still provided pantry services to students and then started giving pantry services to the community, the surrounding community of Medgar Evers College. And soon after that, he became Dr. Wally Boone. getting a DSW from Southern California University. And I can say I've learned a lot of lessons from Dr. Boone, but one of the biggest lessons I've learned is that we need to give flowers to those while they are here with us, while they are striving, while they are healthy, while they are physically present, not for their funerals. So that is why today we are presenting Dr. Boone with a citation from the Office of Brooklyn Borough President Antonio Reynoso. And I'd like to read it for everybody. So, whereas it is a time-honored Brooklyn tradition to recognize those organizations and individuals that have demonstrated an outstanding commitment to promoting excellence and service in our communities, it is therefore fitting that we join in acknowledgement of their special events and occasions. And whereas all of Brooklyn joins today to honor and recognize Dr. Walik Boone. Whereas, on behalf of all Brooklynites, I celebrate Dr. Walik Boone for his dedicated work at Medgar Evers College with the Transition Academy. I applaud Dr. Boone for establishing the Transition Academy, ensuring that no student is hungry or goes without proper housing while attending college. I thank him for running this campus pantry and upholding the health and well-being of our borough's students. I recognize him as a tireless advocate for his students and community, and I thank Dr. Walik Boone for all that he has contributed to our borough in helping our communities to become a much more livable Brooklyn for all. Now, therefore, I, Antonio Reynoso, President of the Borough of Brooklyn, do hereby confer this citation onto Dr. Walik Boone.
You know my bio better than me. It's definitely a surprise and an honor to receive this. I'm definitely humble. But anyone who knows me, I don't do the work for accolades. I do the work to save lives. So when I encounter or I have interns, what I ask them to do, I do it myself. We are a team. And to put this conference together, I know they say me, it's a team effort. We all put the work in to make sure we bring these issues to the forefront and bring in the best minds, the best speakers, the best advocates to come before you to share that information to you so you can take it back to your communities, to empower your family members, to empower your students, to empower your colleagues. It's very, very, very important for us to do that. So this social work conference is important. And as our president, who's standing right beside me, Dr. Patricia Ramsey, often say, Medgar Evers College have social justice in its DNA. And we have to continue to advocate for that. And one of the speakers mentioned earlier that we can't just speak about it, we have to be about it. Action speaks louder than words. So what are you going to do with the information that you received today? You don't have to answer now. I would know because I would follow up with you. And I would see if change has been made in your agencies, in your communities, which is very important. I just want to thank you all. Thank you all, my committee members. Thank the borough president for this honor, and there's more work to do. Thank you.
This broadcast is paid for by Medgar Evers College.